Good morning, everybody. We're going to start with the two powerhouses, Julio Alberto Ramírez and Ruth Carrico, both of whom we all know and love dearly here. Their CVs are so long. Julio's is 66 pages long and Ruth's is 38 pages long. Both of them, between the two of them, have over 500 publications. Julio himself about 380. They both have written books and book chapters. I just asked them what they're most interested in, and they said they feel like they're in the candy store now, because even though lots of people are suffering with this pandemic, this is exactly where these two jive. They are both gifted, talented educators, researchers, and clinicians with multiple different degrees between them. I think, Ruth, you've got 2 doctorates and 2 masters, and your first degree from Bellarmine as an APRN was in '76, and your last degree was another doctorate in 2017. So talk about lifelong learners and people that push themselves. It's these two sitting in front of you. Both of them are experts in global health and have had tons of experience and are on multiple NIH sections to help with things like bioterrorism, infection control. So I don't know of anybody other than these two that could give us a really scientific and well-touted update on COVID-19 vaccines. So I'm going to just let you guys go for it, and I really appreciate everyone's attention.
Thank you very much. Thank you for the introduction. Then here with Ruth, we are going to try to give a presentation in approximately 40 minutes to allow plenty of time for comments and questions. And I'm going to start the outline of this presentation. We are going to discuss 5 points, a little bit of the natural immunity of COVID-19, then a review of the more advanced vaccines, our work with the Vaccine Research Clinic, and the work with the Louisville massive vaccination program. If we were to review the natural immunity in COVID-19, we all know that this virus is an RNA virus, and the attachment protein is the spike glycoprotein. Going a little more in detail with the virus, there are 4 structural proteins in the virus: the spike protein, the envelope, the membrane, and the nucleocapsid. Some of you may remember that our PCR that we're doing essentially detect the genes for the N protein. It's the N1, N2. But there are other PCR that detect either the gene for the E protein or even detect the gene for the S protein. Now, the RNA of the virus, once it's inside of us, is going to produce series of proteins. And here I express the viral RNA going to produce 29 proteins. And the S protein that we are mostly interested has approximately 1,300 amino acids. And essentially, once we have a natural infection, we are going to develop antibodies to multiple proteins. But we are interested in the S protein because we know that the S protein is the one that's going to attach to the angiotensin-converting enzyme that is present not only in our epithelial cells, but also in the gastrointestinal tract. I mean, this is present in multiple organs. Hence, the SARS-CoV-2 is a multisystemic infection. The virus enters the cells by endocytosis. Once in the cytoplasm, this virus and the nuclear the RNA never get into our nucleus. Once in the cytoplasm, the RNA is liberated, and there is when the polymerase of the virus make copies of the RNA. Now, some of the viral RNA is going to go to messenger RNA that are using our ribosomes, is going to produce all the different viral proteins. This is going to generate new viruses that are going to assemble in the reticulum endothelial system in our cytoplasma, and then new viruses are going to be released. And we know that from the very beginning, the virus that originated in Wuhan, soon after the first viruses, they were talking about the European variant and the North American variant. And when we started looking at the COVID in Louisville, really, we identified some of these variants from the very beginning, the European variant and the North American variant, because the virus seems to be right to the United States from Europe as well as from Asia. The point is that all these variants have changes in the amino acid at different proteins in the virus. What is different now is there have been some changes in the amino acid of the S protein. And this has generated all these variants that we are now very interested, as the variants in the United Kingdom, the variants in South Africa, the Brazil variants, and now the most recently identified, the California variants. And these changes in amino acids in the S protein has produced viruses that are more able to attach probably to the ACE2 receptor, and these viruses then are more easy to transmit, and also may alter the way that our immune system responds, and some of these viruses may be even more virulent. Then this is how the variants emerge. Now, we mentioned that in the natural history of this infection, as our cells get infected and viruses are released from the cells, then our immune system is going to recognize the virus. We have the antigen-presenting cells that's going to present all the different viral proteins into our immune system. And in one sentence, we can say that B cells are going to be activated. B cells are going to move to plasma cells that are going to produce antibodies. Some of the B cells are going to be memory cells that are going to go to the bone marrow and wait for the next infection. We know that the CD4 helper T cells are going to be also activated. It's also important the activation of the T cytotoxic cells that are going to recognize cells that are infected with the virus and destroy the virus. And we are going to be able to measure all this in the way of the antibody production, as well as cytokines such as interferon, that is an antiviral cytokines, and other levels of cytokines. What is important from all the antibodies that we produce, because we're going to produce antibodies to all the different proteins that the virus has, but the most important is going to be what we call the neutralizing antibodies. And these neutralizing antibodies are specific antibodies against the spike protein, because we know that if we were to have antibodies that are going to block all the S proteins, essentially this virus then is going to be around the body, but it's not going to be able to attach to the ACE2 receptor, and essentially the infection is going to be stopped. And looking at this natural immunity in this very brief review of immunology of the virus, this is why 100% of the vaccines are interested in given to the antigen presenting cells, all have the same mechanism, the spike protein, and then our immune system to produce the full activation, not only to produce neutralizing antibodies, but to have plasma cell memory cells, T cell activated, CD8 activated, and then to have a robust immune response. Then with this background, now let's go into what we discussed, protein-based vaccine. The idea of protein-based vaccines is that we're going to offer to the person who's going to be vaccinated the proteins of the virus. And the first vaccines developed for protein of the virus is essentially we have the SARS-CoV-2 virus, we inactivate the virus. Usually we culture the virus in cells. We use some chemicals to inactivate essentially the nucleic acid, the RNA. That is an inactivated virus, and this is what we're going to inject. We know that is we have a lot of experience with the influenza virus, with the inactivated influenza vaccine every year. There are other vaccines such as polio, hepatitis A, rabies that use this mechanism. And at this moment, globally, there are probably 3 companies that have finished the phase 3 studies. Sinopharm in China, Sinovac in China, and the biotech in India. I cannot give you too much information regarding this vaccine because this phase 3 study has not been published yet. Then we don't have the full information, even though these vaccines has been essentially have emergency use authorization in several countries and have been already been used in multiple countries. Then moving into another way to present the essentially the spike protein to our antigen presenting cells is to do recombinant proteins. And for this, for the non-ID people, we get the cells, we get the DNA of the cells, and we recombinate the DNA into this DNA of the cells. Then essentially we incorporate this back to the cell, and then these cells in the laboratory produce the spike protein. Then we have essentially a production of the spike protein by cells, and then essentially this is what we inject. We inject the recombined spike protein. The first company that developed this was Sanofi with GlaxoSmithKline. During the phase 2, the number of neutralizing antibodies produced by Sanofi-SmithKline was not too ideally, and they are going to be moving into phase 3 probably soon after modifying the vaccine. Another possibility to give the spike protein is another modality is that you generate the protein using cells with a recombinant protein, then you have the spike protein, and then you have like what is defined as a virus-like particle. These are nanomolecules that looks like a virus. Then you put the spike protein into this viral-like particle, and this is what you inject. Then this is the modality of viral-like particles, and essentially Novavax is the company that have used this modality, and for Novavax, we have some recent data, even though it's not peer review, it's just a press release, but we know that the efficacy has reported 89%. An important thing is that a large number of the patients enrolled in this study were in the UK already look at, and the vaccine is very effective against the UK variant. And this is data from Novavax. Then these are the protein vaccines that we discussed: inactivated vaccine, recombinant protein vaccines, or viral-like particles. This would be the traditional way to develop vaccines. Now we move into the gene-based vaccines. And here, essentially, what we do is we give the genetic instruction of the SARS-CoV-2 for our own cells to develop the spike protein. Then looking at the different methodologies for gene-based vaccines, the first one will be what is defined as the viral vector vaccine. Here we have the SARS-CoV-2, the RNA of the SARS-CoV-2, however, transcripted goes to DNA, and then the DNA, having the genetic information of SARS-CoV-2, get incorporated into a virus. Then this virus is going to be injected to the person that's going to receive the vaccine. And this virus is going to have the genetic information. Now, the virus is going to get into our cells. And the virus is going to attach to our nucleus. The DNA is going to be in our nucleus. The DNA is going to be transcribed to messenger RNA. The messenger RNA goes to the cytoplasm, and the cytoplasm, our ribosomes are going to produce the spike protein. The spike proteins are going to be in the surface of our cells, are going to be recognized by our antigen-presenting cells, and then you're going to have the immunological response to the vaccine. This is probably the most common form of vaccines that we have at this moment for COVID-19, and there are 4 vaccines using the viral vectors vaccine. This is the Johnson & Johnson vaccine, the CanSino Biologic, this is another China company, the Gamaleya Institute, that is the Russia vaccine, and the Oxford AstraZeneca. The difference here is what is the virus that the vaccine used to inject and to incorporate the genetic material of the SARS-CoV-2. In the case of the Johnson & Johnson vaccine, it's an human adenovirus 26. In the case of the CanSino Biologic, it's an adenovirus 5. In the case of the Gamaleya Institute, it's adenovirus 26 and adenovirus 5, 2 different doses with 2 different adenovirus. And the Oxford AstraZeneca is a chimpanzee adenovirus. And one of the issues with this vaccine, with this human adenovirus vaccine, is that if we've been in contact with any particular adenovirus, we may have antibodies for the adenovirus, then we may damage the virus that is carrying the genetic material. This is why AstraZeneca decided to go to a chimpanzee adenovirus that for sure we're not going to have antibodies. Very quickly, what do we know about these vaccines? What we know about the Johnson & Johnson vaccine is and again, we don't have a peer review article, this is just press release by the company, 72% efficacy in the United States. When we look at more severe disease, death or hospitalization is 85% efficacy. When we look at the CanSino Biologic, and the companies say that it's 66% efficacy in prevention of COVID-19. When we look at the Gamaleya Institute, we have the recent article in Lancet, 91% efficacy, very good confidence interval. And according with the report, the vaccine was well tolerated. There were a couple of deaths, but the deaths were not related to the vaccine. And then moving into the Oxford AstraZeneca, we know that 70% efficacy, similar toxicity to other vaccines, early toxicity, and 2 cases of transverse myelitis that this is why this vaccine was stopped twice, but 1 case in a patient that later developed some form of autoimmune disease, and 1 case that was not considered unlikely related to the vaccine. Continue with the gene vaccines. There is the DNA vaccines. And in this case, the DNA vaccines is essentially the DNA of the SARS-CoV-2 is incorporated into the plasmid, and this is then injected. And this plasmid goes to the nucleus, the DNA goes to RNA, and then you have the translation of the spike protein. There's only 1 company working on this, Inovio, a US company, but they are ready to start phase 3 studies. They were still several months to see what happened with the efficacy of this vaccine. And finally, the most important vaccines will be the RNA vaccines, when essentially these vaccines that are completely in vitro, we just copy the genetic material of the RNA of the virus, develop a messenger RNA. The importance of these vaccines is that the RNA is here, is incorporated, goes to the cytoplasm, it goes to the ribosome, and essentially this production of the spike protein. These vaccines are produced completely in vitro, and the RNA is very unstable. This is why you have to have all these nanoparticles around, and these nanoparticles, what we learned, for instance, in the case of Pfizer and Moderna, to make these stable, you have to maintain these vaccines at very low temperature. Then for this vaccine, we have Pfizer working with biotech, Moderna working with the NIH, another German company, CureVac, working with JSK. And what we know from these vaccines, Pfizer published New England Journal of Medicine, efficacy 95%. We mentioned storage -70. The regular initial reactions to the vaccine, and then some anaphylaxis reaction, severe anaphylaxis reactions, and some case of Bell's palsy. In the case of the Moderna vaccine, very similar efficacy. In this case, studies at -20, similar systemic adverse events with the vaccines, and serious adverse events, again, some anaphylactic reactions and some episodes of Bell's palsy. Then moving into the CureVac vaccine, they just started the phase 3, and the interesting story is that this is another messenger RNA vaccine, but it's essentially stored at a regular refrigerator and can be used 24 hours at room temperature once the vaccine is regenerated. Then it's going to be 3 important companies in the area of RNA vaccines. And this has been a brief review of the vaccines. I'm now going to move to Ruth, that's going to continue with our vaccine research clinic. Ruth?
Thanks. It's a great overview, and it, I think, shows then the complexities that are involved when you're looking at vaccines and then trying to incorporate vaccine research, especially into the adult population. I think our pediatric colleagues do this very, very well, have a tremendous amount of experience. Adult immunization has not really been at that same forefront, and some of the challenges that we have had with vaccine research has been based upon that having not only locations, but being able to engage adult populations in vaccine studies has been quite challenging. Here at U of L, I guess we've been doing the vaccine studies with adults for about the last 10 years. We've done some studies with the C. difficile vaccine in the past. Currently, we're looking at yellow fever and hepatitis B vaccines. So when the opportunity came up, when we were approached by Johnson & Johnson to participate in the COVID-19 vaccine, the adenovirus vector vaccine that you described, then we had some level of experience, although this was truly at Operation Warp Speed. And as you'll see at the bottom, we started discussions in late July. We were selected as a vaccine site. But we were not activated. We were activated the first part of November with a telephone call that was, in essence, can you start enrolling patients tomorrow? So it took us a couple of more days than tomorrow, but we started enrolling the first patients on November 21st, and it seemed that every day the inclusion criteria changed because they were, of course, in a lot of hurry to get all of the information together so they too could apply for EUA, or the emergency use authorization, to make that vaccine available. So we really had about a 3.5 week or 4 week enrollment process to get everybody involved. So our approach, as we first had the discussion, was to really reach out to the population that has been of tremendous interest to us, and that, of course, was the healthcare worker population, because our emphasis has been on supporting healthcare workers, understanding those particular needs, protecting healthcare workers, and then what needs to be done then in the system surrounding healthcare workers to make sure that they are safe to come to work and actually willing to come back to work. So we started a process where we solicited interest among the healthcare worker community, and then naturally had others from the community to sign up, let us know if they were interested, so we could then begin some active communication in preparation for first enrollment. Interestingly, just that kind of very mild outreach that we did quickly resulted in over 3,000 individuals that wanted to be involved and participate in what we were calling the Vaccine Registry, because at this time we had no clue how much vaccine was going to be available. We only had the protocol to review and not all of the entire protocol to review to make decisions about participation. So we were very eager to get involved, and of course very eager to make sure that we had accurate representation in the vaccine studies that were reflective of the community, because that's been a very important component for research in Louisville. And that the fact that, as we have discovered with many of our other research studies, that Louisville is actually a microcosm of the United States at large. So when you look at census characteristics, Louisville looks very much like the U.S. So whatever happens in Louisville with respect to disease incidence. We can extrapolate up in many circumstances and then show what this might look at on a national level. So we really wanted to include the population in this vaccine registry. But we quickly found that what others talked about and what we have known all along, that it is very difficult to make sure that we have good participation across all demographics, and so we continue to be challenged by this. Well, one of our approaches in addressing this was to have some education. So we had a series of YouTube and Blue Jeans and other Zoom connections so that we could have individuals that were in that registry join us, begin to have some shared information about immunization, be able to take questions, and really begin to listen to the population that we were targeting to hear what is it that you are interested in, what are challenges, what are barriers, and so forth. So as we push forward with not only recruitment but education, we were able to be very focused and very intentional in those activities. We began then this trial in Med Center 1. This is the picture of the office door where we have had the vaccine study, and I'm not sure what that is. The vaccine study, and this is the same place as our post-COVID, we were calling post-COVID, but the long COVID research clinic, so we could have all of this combination together. So just some pictures of our activities, and we have the laboratory capabilities. It's structured very much like the type of clinic where we can do then very personal interactions. And the study every day as we move through, we had a new component to add. So we needed to be very agile and then have the space and the structure within this clinic to be able to address the many questions, because so much is on the individuals participating in the study to provide back real-time information about their health conditions. So kind of a new level of those e-diaries. And so we had a lot of technology components as well as just the interactive interpersonal relationships with the participants. So that was probably one of the most rewarding aspects of this trial, although it was very, very quick. And now we are in the point where you've probably read that J&J has submitted their information to the FDA in seeking the emergency use authorization. This will be a one-dose vaccine at present, although there is also an additional study looking at the impact of 2 doses. So we'll wait for the review of their data and then what happens from the FDA, and then the resultant guidelines from the CDC through the Advisory Committee on Immunization Practices to see where we go with that. But I think we're all expecting that pretty soon we'll have yet another vaccine that we will be adding to the immunization process. All right, so now what do we do with all of this? So I think one part of of our activities here, and it's amazing as we've gone back through and looked at all of the work that we have done just during this pandemic, and how we've been able to pull together a lot of areas of expertise and experiences, immunization, and actually applying what we learn and bringing what we learn to the community. This has been another opportunity that we've been able to build on some experiences. So many of you, you've been around a while, you probably remember that in '95, we actually had the first drive-through vaccination event on record in the United States and worldwide. So we had CNN here, and they were chronicling this because everybody was saying, well, who would want to have a vaccine in their car? And we thought that probably people would want to do this, and from the infectious diseases and infection control perspective, having the ability to isolate people in their car when you're dealing with a respiratory illness is ideal. So our first year, we vaccinated 300 people. 5 years later, that had grown to vaccinating 3,000 during that season, and all of this was occurring here in downtown Louisville. Now, when we had a drive-through, we were looking very much at how safe it was, not only how the general public would accept immunization provided in a very non-traditional way, but was it safe? So gathering all of this information and actually putting together the procedures of these how-to procedure manuals that we shared with health departments and emergency management agencies, not only across Kentucky, but across our region. And it just coincided with a lot of the bioterrorism planning that was going on at that time. We were highlighted in the Courier Journal. It was nice. This was the ad. You'll remember, those of you, again, that have been around a long time and have seen the number of logos that we've had for University of Louisville Hospital. This was one of them. And then our tagline at that time was, "It wouldn't be the first time you killed a bug with your car," bringing in then the whole notion of immunization, again, in that non-traditional car setting. Because of the amount of interest, we put together this how-to manual in a book. It was shared with every public health department, state public health department in all 50 states and 6 countries that I know of. Those are just the ones that I worked with. And then it was adopted by the National Association of City and County Health, County and City Health Officials, or NACHO, as the model for any type of mass dispensing of anything. Now, remember, in 2006, this was when we were looking at, would we have to distribute pills for anthrax? Would we have a vaccine for distribution, primarily looking at influenza, avian influenza, and so forth. So how this could work then on a community approach, our process was adopted then and distributed as part of this very influential public health approach. Then we began to have to address this real time in Louisville in 2009 when we had the influenza, H1N1 influenza issues. So the concern was, how could we distribute vaccination quickly to the public? We had a joint activity between the university and Louisville Metro Public Health and Wellness. Again, used the planning documents that we had from our smaller drive-through flu shot process to scale it up. We worked with a number of new partners. This was the first time that we'd worked with our industrial engineering partners at the Speed School that helped us with modeling and simulation and help us really look at how could this process work if we begin to scale it up. So this was the aerial view that we were in the public health journals that year, were a highlight for a number of their activities. This was when we used the football stadium at Papa John's Cardinal Stadium and had this massive drive-through event. Again, we looked at safety, so I had an attorney that helped me review the legal literature to see, is there anything in the legal literature that would show us, give us any inkling that this was not safe? Was there anything that was going on outside of our knowledge? And we didn't find anything in case law or in any other publications or even social media that would give us an idea that this was not safe. So we began then to move forward. So fast forward now to about 2 months ago, we began to work with Louisville Metro Public Health and Wellness in their planning. LUVAX is the Louisville vaccine. This is the mass vaccination initiative that is currently at Broadbent. So we translated then our plans from our drive-through at UofL, the football stadium, to Louisville Metro. They were able then to procure state property. That's the Broadbent Arena. That's where if you've ever been to a monster truck show, you were in Broadbent, or if you go to the alpaca show, you were at Broadbent. So it's just a massive arena that has been fitted with the ventilation systems to allow then cars to be inside, and the flow through of the air and the ability then to bump up air exchanges makes it an ideal location for an indoor mass vaccination arena. So this was all structured looking at use of volunteers, because no one has a workforce that is not otherwise occupied during this time that would be able to make such an event happen. So this has been largely volunteer driven with the public health infrastructure and support. So we had some drones that flew around outside just to begin to take some aerial photos so you can see what that looks like outside of Broadbent Arena. The population that's been there is determined by the city. These are generally the directives of the governor, and they work with a lot of very specific groups. The hospital systems now are working with patient groups. Broadbent now has been for example, right now we're finishing up vaccination of educators, of teachers, K through 12. Inside the arena, it's structured again just like we did outside at the football stadium, where we have individuals that are able to drive through and have information collected from them, assurance of safety, and then we have a very standardized, regimented process for administering vaccines, so it is safe. UofL has played a very important part in this because, as I mentioned, Broadbent is where you do the monster truck show and the alpaca show, one right after the other. So it's almost like giving vaccine in either a big garage or a big barn. So, we have three areas of emphasis. One is protecting the vaccine, two is protecting the patient, and three is protecting the healthcare worker. So UofL was instrumental in enabling this to happen by relocating 3 biosafety cabinets that enable then a protected environment for preparation of the vaccine. At present time, only Moderna vaccine is being used, but discussions are ongoing with being able to provide Pfizer vaccine, so that requires reconstitution, so a different level of pharmacy protection. So we will have then retired pharmacists and other healthcare workers that are preparing the vaccine. Again, a very regimented process to ensure that a vaccine, once the vial is pierced, that it is administered within 1 hour, so we can make sure then that we don't have any compromise of the vaccine with the environmental conditions. A lot of workers have been involved, healthcare workers and others. We've had a number of individuals come to Broadbent to figure out what's happening in Little Louisville, Kentucky. Wall Street Journal was there, a big write-up last week. The New York Times was there. So we were on the front page above the fold. So that was a nice tribute to the work that has been done. Very much a community collaboration. I think that's been one of the greatest things that we have accomplished and been able to really build on, and that is the partnerships that have occurred through the coalescence of research, teaching, and clinical practice and service. This is happening then through the opportunities then to bring together what we are doing with research through the Center of Excellence for Research in Infectious Diseases. We are Pfizer designated center. Primarily, research funding has come from industry, not all, but a large proportion from industry. And then our training center, we have received funding from CDC to actually help train healthcare workers working on the front line, as well as healthcare workers that are responsible for infection prevention and control programs in all settings where healthcare is delivered. So we've used in our connections with large healthcare worker groups and our relationships to begin to bring what we are learning through research, translate that into what it means to apply it into clinical practice. And I think that what we are seeing is that what is happening is clearly for the betterment and the protection of our community. So at the end of the day, I think all of us want to feel like what we do makes a difference, that our work, our life has meaning, and this truly has provided us with the opportunity to, again, as Julio mentioned, take what we have been studying for the last a long time. I hate to actually put a number. It's kind of scary if we think about that. But to put into play then what we have been doing and then see the benefit for the community. So with that, I think we can stop and then take questions, or is there anything you want to add?
I think that one thing that is also show the experience is I say, I want to talk 20 minutes, you want to talk 20 minutes, and we did it.
We did. All right.
Only 40 minutes. Thank you very much for your attention.
That was fantastic. And I do have a question. Well, I have two questions to start the questions. One, you demonstrated the complexity of vaccines and multiple targeted proteins and multiple different way to make vaccines. But you also talked about the efficacy, and with the synthetic RNA virus being 95%, my big question is, why do we need other vaccines? My second question is, do you anticipate needing a booster? Because I think you're going to tell us you don't really know how long this immunity might last. And is that why these other vaccines may be important?
Yes, well, just to each one of these questions is a different total presentation, but just to mention that at this moment I lost track of the human population. I don't know how many billions we are talking, but since this vaccine will have to reach every human in all countries of the world, I'm sure that I discussed today the 12 vaccines that are more advanced. We know, according with the World Health Organization, there are more than 200 vaccines in development, and I'm sure that there is going to be enough humans for all these vaccines. The challenge, of course, as we mentioned with the with the Pfizer and the Moderna vaccine is the need of freezers. And this has been a challenge even for the United States. I remember that when we discussed initially we are going to bring either Pfizer or Moderna, the question is, where are the freezers? And I remember in one of the ACIP meetings several months ago, people said, well, we need to start buying freezers. Then I think that these two vaccines are excellent and very good for probably countries like the US, but still even in the US, going to the countryside is going to be a challenge. Then it's going to be a space globally for all types of vaccines.
I think that's been a big issue when we look at how do we actually take this to the population in the mobile clinics, or how are we going to get to them? So we're having a lot of challenges and really having to develop some of those mobile clinics based upon the type of vaccine that we have, the conditions that we have under which to prepare those vaccines. And that makes it then, in addition, you may have a population where they may be very transient. You may not be able to find them for a second dose. So perhaps then a single dose vaccine may be the one of primary interest. So, combining that population.
Everything that we know of vaccines is being studied now with COVID-19 vaccine. For example, I didn't discuss, because I discussed the inactivated COVID-19 vaccines that were already in use. But there is also the essentially the partially inactivated. It's the same that we have for the flu vaccine, that we have the flu mist, that is the virus, this is the influenza virus that is not completely killed. Well, there's also vaccines that are going to be at this moment in animal studies have been tested with the idea to have a nasal vaccines. And I'm sure that over time, every vaccine that we have has been developed here is going to be a need for all these vaccines. Because one of the challenges for all the vaccines that we have now is that we don't know how well we are going to have antibodies, IgA antibodies in our mucosa, to the point that when the virus wants to attach, the virus is not able to attach. At this moment, these vaccines are excellent to produce essentially neutralizing antibodies. Then when the virus wants to get into my lung, I have antibodies there. But I want to be able to get the virus and transmit the virus even if I'm vaccinated. Well, this is why we know that Ruth has the 2 doses, I have my 2 doses. But now we were just been checking to be sure that we are PCR negative, but otherwise we are supposed to be with a mask with any other person, because you don't know, you may be carrying the virus even if you have the vaccine.
Julio, can I ask a question? Chef Callan.
Yes, Jeff. Yes.
Yeah, so I have several questions. One is, what advice do you give about our patients who are on a variety of immunosuppressive agents, particularly methotrexate, mycophenolate, azathioprine, TNF inhibitors, rituximab? Should any of these be the dosing or be interrupted, be changed at the time of the vaccination or following the vaccination? That's my first question.
This is an excellent question. Of course, just for the general public, we know that the efficacy of the vaccine, because the one thing is efficacy, other thing is effectiveness. The only thing that we know for this vaccine is efficacy, meaning phase 3 clinical trial, randomized vaccine versus placebo. And all the protocols for the vaccines exclude the immunocompromised patient. Then going back to, okay, what data do we have for immunocompromised? We don't have any data. But as you alluded, the ideal situation to vaccinate an immunocompromised patient is when the person is less immunocompromised. And we've been discussing this in adult vaccine forever, but I may say it's important now because everybody's going to get this vaccine. And to me, if the person is on the waiting list for a transplant, well, this is the time to vaccinate the person. Please don't wait to get the kidney, to get the liver, and then figure out after the liver transplant, can I get the vaccine? This patient needs to be vaccinated immediately, because we don't want the person to be immunocompromised. Now, you alluded, once the person is immunocompromised, what we've been discussing with other vaccines is that if the person is able to stop the immunosuppression for 30 days, then if we are able to stop the anti-TNF for 30 days, then stop 30 days, give the vaccine, and then wait 2 to 3 weeks before you restart. And the question is, are you going to be able to have this patient with a severe rheumatoid arthritis for essentially 2 months without immunosuppressive medication? This would be the ideal situation.
And my next question is,
I was going to say, I think that brings up also the challenge that we have right now is that when you're in clinical practice, you're looking at your patient that's the N of 1. When you're looking at mass vaccination, you're looking at a population-based approach. And so then it's like if the vaccine won't hurt you, it may provide some benefit. So no vaccine is zero benefit. Even vaccine that may provide some benefit is maybe greater than 1. So you may see your patients rolled into, mass vaccination, even though if you were from a clinical perspective, you would give them another recommendation. There may not be an opportunity for them to be vaccinated, say 3 or 4 or 5 months down the road, and it may be, very hard to predict. So that really is a challenge in application of vaccination approach.
But I may say that, yes, the one thing is the person is coming with driving the car and it's too late. But for all of these patients, if the possibility exists to stop the immunosuppression, no question, because at this moment, once the person is immunosuppressed, we know that this 80, 90% is going to drop. It's going to drop at least 50%.
So my next question is, around the time of the vaccine, your arm hurts. People tend to take an over-the-counter non-steroidal. Is that a problem?
I think that at this moment, I asked this for some other people that are working on. I have a conversation with a group from the Pfizer vaccine, and they said no, and I agree, because at this moment I may say that you get the vaccine. It's very important that the antigen presenting cell is going to bring the protein to the lymph nodes. It's very important that your B cells are going to work. Then I don't see a problem for aspirin, Tylenol, or non-steroidal anti-inflammatories blocking any part of this immune response that we want to have as healthy as possible. On the other hand, if someone say, well, the person is allergic, is an asthmatic, and I want to prevent an allergic reaction, let me give some steroids. I would say no. Let's don't give steroids to a person in preparation for the vaccine, because then we know that with steroids, your B cells, your T cells are not going to work properly. Then I will not have any problem for the non-steroidal anti-inflammatories. I will have problems for anything that goes beyond this that may affect somehow, because even if we know that the white blood cells needs to move to the area of the vaccine, then we know that movement of white blood cells get affected by so many drugs, even by alcohol. Then I would say that be as healthy as possible before you get the vaccine. Stop your prior night, yes, scotch, and be healthy. But I don't think that there is a problem for the non-steroidal anti-inflammatory. Now, having said this, let me, because there's a lot of people said, I have all these friends that develop fever with the vaccine, and I want to take something for the fever. With Ruth, we have our storyline that we use in our vaccine clinic all our life, is that once you get the vaccine, the problem is the vaccine doesn't work. And the vaccine doesn't work if your antigen-presenting cells doesn't bring the antigens to your B cells, T cells, and you don't produce the cytokines in response. Because in the lymph node, it's going to be production of cytokines. For the B cells to be activated, go to plasma cells, produce antibodies. Then, once you get the vaccine, if you get fever, that is for interleukin-1, if you feel bad for the interleukin-6, you're supposed to be very happy because your immune system is developing antibodies. Then I don't know why the FDA called these adverse events to the vaccine when, from our perspective, is the normal physiologic response to the vaccine. Then I got my first dose. I feel awful for 2 days. I was so happy. I got my second dose. I feel awful again. I was even better. I mean, I'm so happy that I have this bad reaction to the vaccine. And I decided not to take anything. I was able to work, feeling bad, but I may say you have high fevers, take something after but be happy that you respond. You have a very good response to the vaccine.
So there are a couple of questions. I don't know if we want to try to take a couple that are in the chat. I think that may be kind of quick. One of them is, do we need to quarantine after the vaccine? And the other is, can you get COVID between the doses of your vaccine?
Yeah. Quarantine after it has to do with the second dose. For every vaccine, this vaccine is no different. You need 2 to 3 weeks to develop antibodies. And for these vaccines, we know that with the Pfizer, Moderna, after the first 2 weeks with the first dose, you are more or less protected around 50%. It's with the second dose, after 2-3 weeks, that you are more than 90% protection. Then essentially, I may say that if you were working from home and try to be not in contact with other people, because you get the first dose, you have to remain. You can still get COVID after the first dose because only 50% protection. Now, in our vaccine trial, for instance, you have a person who received the vaccine. The question is, how many days after the vaccine you need to have COVID for this to be called a failure of the vaccine? Because you need to give time to the vaccine to generate antibodies. Because then we have patients that receive the vaccine and in 5 days develop COVID. Well, it would be unfair to say that this person developed COVID and it was a failure of the vaccine, because in 5 days you didn't have a time to develop antibodies. And these are things that, again, clinical trials have to make the decision, okay, after these days, every COVID patient is going to be counted as part of the COVID in the vaccine trial. We have a healthcare worker that received the vaccine that a couple of days later developed COVID, but it was immediately after the vaccine. Well, it was not a failure of the Johnson & Johnson vaccine. It was just, he just got COVID. There's a lot of patients that receive the first dose and then develop COVID. And then the question is, if I develop COVID, should I go for the second dose? As Ruth mentioned, the overall answer is you follow the same criteria that you have. You have 21 days, you have 4 weeks, follow and get the dose at the time. Even now, then there is another factor here. For every vaccine in adults, we always mention, since we give you the vaccine and you want your immune system to be 100% concentrated in this antigen, if you are having any other problem, if you have sinusitis, we say, well, don't get a vaccine if you have sinusitis. So your immune system is working with whatever bacteria is in the sinus, and we want the full immune system dedicated to answer the response. Then let's say that the person has a first dose now. He's ready to get the second dose at day 21, and at day 19 develop high fever, and he's developing a COVID pneumonia. Do I want, in the midst of a COVID pneumonia, give another individual? I would say to this person, wait until you get better of COVID, and then you get the vaccine.
I want you to don't come out of isolation.
Yes.
Get a vaccine.
Yes. Then, as Ruth mentioned, one thing is public health, the other thing is one-to-one.
So I think the question about the quarantine after, do you need to do you have an exposure after vaccination? I think the CDC just came out with a statement yesterday or day before that indicated that you do not need to quarantine if you have had an exposure after you've received both doses, but also kind of at the end of that, the little caveat that, well, we only have data for 3 months or so after post-vaccination. Mm-hmm. So after 3 months of vaccination, we don't know what the effect is of your vaccine.
Yeah,
that's still part of the study.
There's also so many things as we have. Quarantine for what? Quarantine because I'm going to get COVID and then I can have a lot of, well, probably you're not going to get COVID if you have the 2 doses of the vaccine, or is it less likely? But as we discussed before, I get the 2 doses of the vaccine and now I've been exposed to a person with COVID. Well, I'm not going to get the vaccine, but I may bring COVID home because I may still be able to carry the COVID with me in my nasopharynx. then the story is that you don't need to be quarantined, but we need to use mask or double mask or whatever is going to be now the story of the mask, even if you have the vaccine. And then, of course, with the variants now, it's going to be even more important. Now that we recognize that some of the variants are already in Louisville, then it's going to be even more important because we don't know. We know that for almost any vaccine, the variants, the effectiveness decrease. And we know that almost any company, I get the 3 companies with the RNA vaccine, they are already working on vaccines for the variants. It's going to keep coming.
Do you want to continue down the chat questions?
Yes, we still have 5 minutes.
Right. So, Dr. Hesselbacher, with respect to the RNA viruses, what human cells are conscripted to make viral proteins? Are we bypassing the normal immune system? For example, can liver or endothelial cells transcribe the nucleic or nucleic acids?
This is it's very interesting to discuss this high-level pathogenesis because I have a long conversation with a scientist from Pfizer to discuss exactly this type of things. To discuss, okay, we have the antigen-presenting cells, but what happened with the cells in my muscle? Is the cells in my muscle covered in the surface with a spike protein? Is the antigen-presenting cell bring the antigen to my lymph nodes? Some people have swollen lymph nodes, axillary lymph nodes. This means that the antigen is presented only by the antigen-presenting cell, by the dendritic cells that get the antigens in the muscle. The dendritic cells beam the antigen. What happened with other cells? There's a lot of things that we don't know. These are new vaccines, and these are vaccines that are being tested in. But what is also interesting, there's a lot of things that we don't know for all the vaccines. We are having all these very interesting questions. Then, what cells in our body are covered with this spike protein? And then, of course, I was thinking, you have these cells covered with a spike. It's good. Our antigen-presenting cells get there, develop the spike protein. And then they go, and then I can see the T cytotoxic cells that are investigating what cell is infected. Oh, this is a cell with a spike protein, eating. Then now the good thing there is that after a period of time, after a short period of time, every cell with a messenger RNA is gone. Meaning that either the messenger RNA get destroying the cells or the cells are eliminated. This has been also the problem, is that the messenger RNA get there, but are you going to generate enough protein before cell destruction that the immune system is going to develop enough antibodies? But it seems to be that there is nothing after a short period of time that all these RNA or these genetic things that we put inside, we're not going to have any one of our cells alive for a long period of time with any one of these genetic material. But again, your question is very good, and I think that we don't have a full answer.
So I think Paul asked this. ACE2 receptor is present in the GI tract. Is there potential for an oral COVID vaccine?
But yes, people, no, definitely. People are working on the nasal and the oral COVID vaccine. I know that these are in animal studies. And some people say, well, by the time that this vaccine goes to humans, phase 1, phase 2, phase 3, maybe 2 years. But still, as we more and more discuss that the variants are going to keep coming, and this is going to be probably an annual vaccine, it will be great, even if in 3-4 years we have an oral COVID vaccine. This will be excellent. And a spray and an oral that I cover my nasopharynx and my GI tract, and then the virus cannot get in. All these are things that what is interesting that, yes, people are working on this already.
I think here was a question asking about the if you have COVID between the vaccines and are asymptomatic and are asymptomatic, can you still receive monoclonal antibodies? So I think this is kind of an interesting overlap. And at present, the team is the investigation team working with Lilly for long-term care facilities across Kentucky and now Indiana to bring the monoclonal antibody to long-term care facilities. So it's a little bit of rapidly gaining experience in doing this. So, what
this will be probably this could be our next grand round whenever time arrives, because monoclonal antibodies are the new kids on the block. As Ruth mentioned, Lilly is working with the NIH, and they took this special approach that they decided to have one principal investigator for the monoclonal antibodies in one group, in the monoclonal antibodies for different states. And we were lucky enough that we were selected as principal investigator for the state of Kentucky and principal investigator for the state of Indiana. They were doing the Lilly study in Kentucky and Indiana, primarily in nursing homes. And Ruth had visited several of the nursing homes where we are doing the study. And essentially, again, everybody knows that this monoclonal antibody for Lilly just got emergency use authorization in the last couple of days, yesterday, day before yesterday. And I know that because I've been reviewing the data, and the Lilly is submitting the data for peer review journal, because I just saw last night the last version of the manuscript. Then this is going to be probably in an important journal very soon. Then the monoclonal antibodies definitely are working. Now the concern, and this is a hypothetical concern, is that if I receive monoclonal antibodies and then I have a lot of antibodies against the spike protein, because this is the idea, not the monoclonal antibodies, a specific antibody against the spike protein. Then what we're doing in nursing homes is with this one case of COVID, and then is given the monoclonal antibodies to everyone in the nursing home. There are two possibilities. Either the person in the nursing home already acquired COVID, that is in the incubation period. Then you have monoclonal antibodies for an early infection, even when you're in the incubation period. Or you are going to get the infection, you're going to be infected later on, and then you have almost like you have an artificial vaccine. You have the monoclonal antibodies already waiting. And this is working and protecting. The hypothetical consideration is that if I receive monoclonal antibodies, and I have a lot of antibodies for the spike protein, and if I get the vaccine, and the goal of the vaccine is for our cells to produce spike proteins that are going to have enough spike protein to activate my dendritic cells, to activate the immune system. Could it be that the monoclonal antibodies, as soon as one cell produces a spike protein, the monoclonal antibody goes and blocks the spike protein, and my immune system doesn't recognize that I received the vaccine? And this is the storyline, that if you receive monoclonal antibodies therapy or prevention, wait until the monoclonal antibodies decrease before you get the vaccine. And I understand that now the recommendation is 90 days.
Right, 90 days now and then but at the population-based approach for vaccination, it's 30 days. So again, that, going back to, again, what's good for one patient versus how do you have then a population-based approach for vaccination that you can apply across the setting, because, patients cannot tell you, and I know from the ones that we are seeing going through broadband, cannot tell you when they were treated. Oftentimes will tell you, I was in the hospital and I got something. I don't know what it was. I don't remember what it was, but I got some treatment for COVID. But we know that, we have treatments all over the place, so many different treatments that it makes it very hard.
Well, it's already past 9 o'clock. Again, Ruth, we want to thank everybody for your attention, and we'll try to, every time seems to be that every time that we have a ground rounds, it was already Forrest Arnold giving a ground rounds at the beginning of all this, then Mark Burns giving a ground rounds on therapy, now a ground rounds on vaccines. Probably seems to be that the ground rounds on infectious diseases, we know what's going to be the topic for some time to come. Thank you very much for your attention. Ruth?
Thanks.
Thanks. Thank you very much, everybody. Thanks so much. Julio, Ruth, thank you. Great job. Fantastic. Bye-bye.
Thank you.